Well, my name is Candace Chang, and I'm one of the anesthesiologists here at the University of Utah. And I'm very pleased to present this joint presentation between myself and Professor Momodou Baro from the Gambia. So I will let him take it away. And Momodou, I will control your slides, okay?
All right. Do I have to? Good to go?
Yes. I'll try to keep up.
All right. Good evening here and good afternoon over there. I'm glad to be with you today. And we would talk about the Gambia and the health situation in the Gambia as it is today. As you can see, it is a very little country, which some people describe as an index finger poking into the ribs of Senegal. Next. Next, please. The Gambia is the smallest country in mainland Africa with a population of about 2.8 million from a recent census. Children, adolescents, and the youth make about 64%, and women of reproductive age 25. Population growth is about 3.1%, and it is divided into administrative regions. It is a market-driven economy with service sector moving the largest contribution, and 48.2% population live below the poverty line, while much of the wealth is concentrated in the urban areas. The climate is tropical and characterized by two seasons, rainy season and dry season. The population live births per year is about 86,363. And under 5 population is about 366,000. Under 5 deaths are 6,000. Neonatal deaths are 45% of under 5 deaths. And neonatal mortality is about 100 live births per 30. The total fertility rate in the Gambia is 5.7. Maternal mortality rate is very high. Per 100 live births, about 590. That was in 2017, but in 2020, it has come down drastically to 2.89, which is not even good. We still need to work on that. Life expectancy in the Gambia is 63.5 years. And the average is about 18.4. The HIV prevalence is HIV-1, 1.6, and HIV-2 is 0.4. The democratic change, since there had been a new health policy since 2018, and it has been brought in by the democratic change that has brought a new government and new priorities. The country health program was adjusted to include children and on the move and transitional justice. The reproductive maternal mortality, newborn, adolescent, and child health is a new department at the Ministry of Health with policies and strategic plans. This is a new office, and the country adopted the concept. This is one of the hospitals called Bundung Maternal and Child Care Hospital, which is basically for women and children. There had been some improvement over the last 10 years since the democratic change. There had been an increased immunization coverage of a rate of more than 80%, and there was a decline in communicable diseases and a decline in maternal mortality, as already mentioned. The Ministry of Health has the stewardship of the health system now. There is a primary health care, which is stewarded by the Ministry of Health mainly. It is organized into directorates, which oversee different units under them. The directors are 6, led by directors and deputy directors. This one is one of the hospitals. We call it a district hospital, Brikama District Hospital. There are healthcare providers which are provided by 7 public health tertiary level hospitals, 6 what we call here major health centers, which I will explain later, and you have minor health centers, which are at the secondary level, and 40 community clinics and 634 primary health villages, we call it primary level. These are complemented by 18 other facilities run by non-government organizations. The Gambia health system runs in such tiers as at the lower level, you have the primary level where you have the community health workers, the TBAs, and health center staff. They run community clinics, health post communities, and RCH outreaches. RCH are outreaches for maternal and child health. Then you have the tertiary care, which is divided into 2. The lower tertiary is the major health centers and the minor health centers, which also run services plus NGOs and private health hospitals. And then you have the higher level tertiary, which are the hospitals. The hospitals are the teaching hospital and the general hospitals, and now district hospitals. The first point of contact at community level is the primary level. That is in the villages, at the community level. That's the first contact. Then each primary care setup serves villages of 400 villages. That's what they take care of, each primary care setup. So there are normally two community health workers per village. Each village of these 400 villages have 2 community health workers. You have the village health workers and the community bird companions. Normally, you have 5 primary health villages they take care of and serve them. The minor health centers, as you can see, this one is a major health center. But the minor health centers serve 15,000 to 20,000 people at a time. They are staffed by nurses, midwives, lab assistants, public health officers, and 20 to 40 bed hospitals. The major health centers serve an average population of 150 to 200,000, and they have a capacity of 50 onwards. There is this, they conduct cesarean sections there, and comprehensive obstetric surgeries take place there. This is one of the wards in a major health center, and at the helm of referrals are the tertiary. These are the tertiary hospitals are the general hospitals, which have catchment areas of 300,000 to 400,000 inhabitants. Referrals come from an average of at least two major health centers per hospital. So in this tertiary institutions, you have specialist physicians and an average of 150 to 300 inpatients at a time. This is the oldest hospital in the Gambia. Is called Bansang Hospital and is in the hinterland of the Gambia. It was built in 1938 by the British. However, there are more modern buildings behind this one. This one is Kanifing General Hospital, which is one of the tertiary institutions. It is more recent. It was built within the past 20 years. And the Edward Francis Teaching Hospital is the major referral hospital. And that's where it is at, is the only university teaching hospital. And it was also built by the British in 1853. The health financing in this country is organized through government tax revenue mainly. And the Ministry of Finance and Economic Affairs would allocate funds to the hospital, which most of the time is not adequate. Some private sector operators like banks and NGOs do provide medical cover for their employees or by paying premiums into private health insurance schemes. There is no social health insurance system in the Gambia. However, just recently they have started something similar, but it is at a very rudimentary stage. It is being piloted in various hospitals to see if we could have some form of health financing system. The total expenditure as a 40% of the GDP, which is very low. Out of pocket expenditure is 24% of the total health expenditures. External sources for health, about 36.5 of the total spending. Now, we have a whole lot of challenges if it comes to health services in Gambia. You have unequal access to quality health services. The more money you have, the better services you have. Independent supplies of essential drugs and equipment. Inadequate, supplies of essential drugs and equipment. Retention of trained personnel is a big problem in the health sector. Maintenance of an efficient cold chain for transportation of vaccines is also another problem. And the poverty rate is predominantly rural areas. The maternal health challenges are also numerous. We have unmet need for emergency obstetric care due to inadequate equipment. We lack supplies, we lack personnel, especially in the provinces. There is inadequate blood transfusion services, inadequate laboratory services, shortage of skilled healthcare personnel in rural areas, and referral system from the community is very difficult. There is inadequate budget for reproductive health. Low contraceptive use due to sociocultural beliefs that discourage contraception. There is inadequate life-saving medicines and supplies. Early marriage and childbearing is another problem. There is poor nutrition among the pregnant women. Distribution of pregnant women in the antenatal is also at low level. Now, the scale of the challenge, there is lack of skilled health professionals during pregnancy, especially at the time of birth. Expenditure on healthcare has increased from 61 since 2002, 61%. But per capita health spending is only $28. The minimum recommendation by WHO is 34 to 40% for $40. Source of funding is normally donors are the source of funding because they fund about 46.7%. Now, nursing education in the Gambia, there are a total of 5 nurse training schools, but I think recently there are a few more. The first hospital, which was built in 1953, was a training institution also. It trained nurses before 1950, training of nurses before 1950 was conducted on apprenticeship model, where high school leavers are hired and employed in the hospital, and they are trained on the job as they're working. School of Nursing was set up in 1964 by UNICEF and staffed by WHO expatriates held by Gambians. In 1970, the school became part of the Gambia College. And the American International University started their BSN program in 2011 until now. That is the American International University.
Professor Baro, can you talk a little bit more about how Iowa was founded and its history and kind of who it serves?
Oh, the American International University actually started somewhere in West Africa in a place called Guinea Conakry. But because of political reasons, political instability, the proprietor and the president of the university decided to visit the Gambia and try. The president at the time was very welcoming and provided a plot of land to build this institution. Since then, the American University have been progressing from step to step. We have been having, and we have students all across West Africa, from Malawi in Southern Africa, all over West Africa, we have students there. The College of Nursing, for instance, has 5 departments. You have a general nursing department, and we have RN to BSN programs in different departments like midwifery, anesthesiology, psychiatric nursing, and perioperative nursing. Since then, we have had numerous students who either work in the Gambia or go across West Africa or Europe and America. They're spread all over.
Great, well, thank you.
Let me just finish this. We also have a College of Medicine, which is still on its accreditation process. There is another College of Pharmacy. Then we have a different campus called the College of Management and Information Technology, where they study information technology, economics, accounting, and other courses, non-health courses.
Excellent. Well, Momodou, please stay on, because as you know, I'm going to be asking you some questions, but I'm gonna get my slides up.
And is the nurse anesthesia school in that last?
Yeah.
Yes, it is the first formal anesthesia school in the Gambia. But since 2000, the Ministry of Health, together with the WHO, had been sponsoring a training program which I was doing at the EFSTH since the year 2000. So that is where most or all of the anesthesia practicing nurses have been trained.
And as I was telling Dr. Rockwell before we started, so there's only one permanent anesthesiologist in the Gambia, Dr. Chang. There are sometimes Cuban anesthesiologists who will rotate through as part of their public service, but the vast majority of anesthesia is provided by nurse anesthetists.
Yes.
My name is Candace Chang. Yes, go ahead.
Can you remind us how many teaching hospitals? Did you say just one?
Yes.
And
only
is
one
that the Edward Francis Small Teaching Hospital?
That's
Yeah,
correct.
okay.
We only have one university teaching hospital.
Right.
So I'm Candace Chang. I'm an associate professor of anesthesiology here at the University of Utah, as well as the director of global engagement for my department. And I am going to attempt to summarize our 10-year relationship with Professor Baro and the Gambia in about 25 minutes, if I can. And before I get started, I just want to say that I'm presenting this on behalf of myself and Dr. Scott Junkins, who's a professor of anesthesiology, who's my partner in all things global health, and none of this would have happened without him. And so he's pictured here with Professor Baro, as well as Professor Ka and Professor Ahmad from Iowa. That's what we call the American International University of West Africa, as well as myself. So the outline for my talk, I'm just going to briefly gloss over the timeline of our 10-year relationship. I'm going to review the traditional teaching methods that we employed, how we were forced to innovate during the pandemic, and then when we were able to return in person, how we evolved and deepened our relationship, as well as future directions that we hope to take this in. I don't know where to point. Okay. All right, so Iowa has multiple professional colleges, as Professor Baro mentioned. So we have nursing, pharmacy, business, accounting, computer science, a very small medical school, as well as others. And we were able to visit the university 4 times between 2016 and 2019. So our mission is 100% educational. We have zero interest in providing healthcare capacity, and we want to build and improve the healthcare capacity that they have. But I want to emphasize that our relationship is bidirectional, and we, especially our residents, learn just as much as the Gambians do. And Professor Baro invited us to the country with a focus on teaching the nurse anesthesia students. And then just to review, so this is a 2-year advanced degree program after the students have completed nursing school. So a lot of these students are actually practicing nurses concurrently while they're attending nurse anesthesia school. So between 2016 and 2019, we employed traditional teaching methods. We gave lectures in the classroom. We had small group discussions. And one thing Professor Baro asked us to do was to actually advise the students on their individual research theses. So the nurse anesthesia students are required to complete a thesis before they graduate. And one thing that we noticed when we were reading all of these theses is that their research projects are actually quality improvement endeavors. So some examples of projects were standardization of care protocols, ensuring the availability of safe equipment for anesthesia, as well as the assessment and treatment of postoperative pain. And timing-wise, this happened to coincide with the development of a quality improvement curriculum for our anesthesia residents here at the University of Utah. And it's actually a curriculum developed by the University of Minnesota. And so we actually combined forces with about 4 or 5 universities, and we would co-teach this course online. And this is a little bit of foreshadowing for later in my presentation. The other thing that Professor Baro asked us to do was to provide an annual anesthesia review course in conjunction with the National Gambian Society of Anesthetists. So this usually consisted of a day-long course where University of Utah faculty and residents would give a series of lectures on topics that the Gambians asked for. And these usually included postoperative pain, trauma, as well as emerging technologies. And then COVID happened. So we were prevented from traveling internationally for a couple of years. And so we did what everybody else did, which was log on to Zoom. But logging on to Zoom in the Gambia is a lot harder than it is to log on in the United States. So Professor Baro, can you comment a little bit about the difficulties of electricity and internet in the Gambia?
Yes, the online courses were very useful, but there were setbacks such as outages. We have common electricity outages and inadequate internet bandwidth. That has really, that's a major setback. But that notwithstanding, we have been trying to at least have the lectures, but that is a major problem. Even as I'm talking to you, the internet bandwidth has gone down, and I thought I was not going to be able to access you people on Zoom, but luckily, at least we are still connected.
You can see here that the vast majority of the students don't have their videos on because that would eat up too much bandwidth.
Yeah.
So what did we decide to teach online? Well, as I mentioned before, we already had access to a quality improvement curriculum developed by the University of Minnesota. So I thought that we could adapt that curriculum and teach it to the Gambians. And I think quality improvement is particularly applicable in low resource areas because it is about providing the best care we can with the resources that we're given. It doesn't require fancy technology. It does require an investment in teamwork and time with a focus on sustainable solutions, not quick fixes. And I particularly enjoy teaching trainees quality improvement because they are looking at our care processes with fresh eyes. And so they ask a lot of questions about things that we take for granted or just accept as the way things are. And I like to mentor trainees in quality improvement projects because Hopefully this shows them that they can make a positive change in systems, and hopefully this inspires them to continue this work when they graduate. So from 2022 to 2024, we ran this course online. And so it was a 7 to 10 week course between January and March. We had a course website that had reference articles for each week, as well as PowerPoint templates. And then we had a 90-minute Zoom class with a member of the University of Utah anesthesiology faculty. The first couple of minutes of the course was a quiz. So why did we have a quiz? Well, it was actually a Google Sheets quiz, and it was our way of seeing how many people could actually log on to the internet. So when we had a certain number of quiz responses, then we had a quorum to start our class. The first half of the class was a discussion of the topic with the faculty facilitator, and the second half would be project presentations by the students. We also had a WhatsApp chat. WhatsApp is used quite extensively in the Gambia. And so this was the easiest way for the students to contact the course administrators when they had questions. And I just want to thank Dr. Soumya Mishra and Dr. Scott Adair, who spent dozens and dozens of hours every year for the 3 years to run this course. So I mentioned a project. So we required that the students work on and complete a quality improvement project concurrently with the curriculum. And that's because really the best way to learn quality improvement is just to do it and to learn that way. The students were required to present their progress on their project in class each week. This gave them some experience presenting in front of their peers on PowerPoint. And then with each of the 3 years, we experimented with individual versus group versus paired projects. And we had varying amounts of success. Especially in 2023. I don't know if you all remember, but we had significant staffing shortages here at the hospital. Well, the Gambians also faced the same staffing shortages in their hospitals. So a lot of the students were working more hours as nurses in the hospitals than perhaps they wanted to. So I wanted to let Professor Baro comment a little bit on the impact of the quality improvement course and also the challenges that the students faced.
The course was very useful in that it increased their understanding of QI, and it helped to prepare them for practical implementation at clinical level. They have never had this experience before, and it has really made it easy for them to understand and identify problems and help them solve the problems as they arise. It was a very important tool, the QI.
And did you want to comment any more on the challenges, especially last 2023?
Mainly the challenges are of availability of electricity and internet, for which reason students could not access. That was the most outstanding challenge.
So in running this course for 3 years, we learned a lot. One is that the internet is not free, and that if we can engage in the classroom more, that is definitely preferred. We had to allow for significant amounts of time because of these connectivity issues. It was usually about 15 to 30 minutes of the class time. The students participated very well in the topic discussions. They shared anecdotes, gave comments, asked questions, but they were quite hesitant to present their projects. They also wanted us to incorporate practicing nurse anesthetists more, but we could only run the course at 6:30 in the morning Utah time, which was 1:30 in the afternoon Gambia time, which is right in the middle of the workday for the nurse anesthetists. So, we do think the course was successful in maintaining our longitudinal relationship with our Gambian colleagues, but we needed to return in person to rebuild our relationship. So we were finally able to return last year with 3 faculty members and 4 residents that you can see here. And we embarked on this trip with a mission focused on teaching the nurse anesthesia students. We have traditionally only spent limited time in the operating rooms as observers, and this was because our past experience in both the Gambia as well as in Ghana, we found that the more time we spend in the operating rooms, supposedly teaching anesthesia, we might find ourselves actually providing the anesthesia, which is not our mission. So you may remember that one of the things that Professor Baro asked us to do was to run a national anesthesia review course. hopefully annually. So of course, we wanted to do this in 2024. But when I was thinking of how I wanted to plan this out, I wanted to think long-term. And of course, the long-term goal is that the Gambians will run their own anesthesia review course with us just as invited guests or just observing. And so I thought the best way to achieve this would be with a case conference format. So our morbidity and mortality conferences at the Department of Anesthesiology here have been run by my chairman, Dr. Talmadge Egan, for many years. And I've always admired the structure and the culture that he's built into our M&M conferences, where the focus is on education and collaboration rather than confrontation. So I tried to emulate that in the Gambia. We had an M&M conference with 4 nurse anesthetists. This is MM from EFSTH presenting 4 cases from 3 different hospitals of adverse events, including mortality that occurred during anesthesia. So the nurse anesthetist would present the case. This was followed by questions from the audience to clarify clinical details. Then after that, each of our residents would present a lecture on a topic that was pertinent to the case at hand. And this is Dr. Megan Tupino presenting. And then the most important part of an M&M conference is the discussion. So it was quite risky for us to walk in as foreigners and to hold an M&M conference in a country that we've never practiced anesthesia. And we understood that this was a risk, but we decided to take it. And I'm happy to report that it was actually pretty successful. There was very lively discussion. There was a lot of different opinions expressed, but everything was respectful and collaborative, and there were no confrontations. Did I just have to click something? Thanks. Something I added on to the case conference format that we don't do in our M&M conferences is a focus on systems improvement. In our department, we do this as a separate conference, but one of the reasons I really wanted to focus on this is that sometimes when working in a lower resource environment, there's a lot of things are just blamed on the lack of resources. But I strongly believe that you can achieve significant improvements in patient safety with standardization, protocol development, emergency preparedness, crisis resource management, and better teamwork. So I showed 2 examples that we use at the University of Utah here. So on the left is the Stanford Emergency Manual, which is a cognitive aid that we have in every anesthetizing location at the University of Utah. And for those who don't know, it's basically a how-to handbook that can be downloaded for free online that gives step-by-step instructions on what to do for more than 20 crises that can happen in the operating room. And then on the right, you have our pre-intubation checklist, which is just a list of 8 things that should be verified before induction of general anesthesia. And this is also posted in every operating room. We certainly don't do things perfectly here at the University of Utah. And one of the things that the Gambians do far better than we do is the pre-surgical timeout. So this is a picture of the WHO surgical safety checklist championed by Atul Gawande. And this was posted in every operating room that we saw in the Gambia. And the reasons why they did this far superior than we do is that every member of the team actually did stop what they were doing to pay attention. The nurse led the timeout. The surgeon would give clarifying details about the patient or the procedure that he or she was planning. And the anesthetist was always asked specifically if they had everything they needed to provide safe care of the patient. So Dr. Junkins and I had the opportunity to return to the Gambia in January, and we kind of went in with a slightly different mission, with a focus more on the practicing nurse anesthetist rather than the students this time. And we were really curious with the 3 or 4 months interim, what the Gambians thought of the case conference format and how well they were able to implement that at their own hospitals. And so we were privileged to be invited to 2 hospital case conferences, as you can see one of them here. And we were asked for our clinical expertise, but we also gave them some advice on how to provide case presentations succinctly with all the pertinent clinical details, as well as how to kind of manage the time of the discussion. So in addition to attending the case conferences, we also wanted to ask the nurse anesthetists about attitudes and challenges in putting on case conferences. And so I interviewed 5 nurse anesthetists at 3 of the hospitals with a questionnaire that was developed by Dr. Flora Liu, one of our residents who's seen here presenting at the International Anesthesia Research Society this week. And there's significant differences in the attitudes of the Gambians versus Americans. So one is there's actually very little fear of getting sued when there's an adverse event or mortality. And that's because usually when something bad happens, it is attributed to the lack of resources or even just God's will. There's also very little fear of being fired. You may remember Professor Baro mentioned that there's a lack of skilled medical professionals in the Gambia, so they need everyone they can get. And so the attitude when there's an underperforming nurse anesthetist is that that person is assigned a senior nurse anesthetist who tutors them one-on-one, day after day for weeks until that person is brought up to speed. The other thing is that attendance at these conferences is not an issue at all. Both conferences we attended started a half an hour to an hour late due to unavailability of the conference room. But even with those delays, we had 10 to 15 nurse anesthetists at each conference. There's also a very strong concentration on improving care and wanting to take better care of the next patient who walks in the door. And when I asked them if there was any shame or embarrassment reporting your own errors or your adverse events, they almost thought it was kind of ridiculous that somebody would put their own personal ego above focusing on improving patient care. So we definitely did not ignore the students. And we were able, because I had a quality improvement course that I'm obligated to teach. And so Dr. Jenkins and I taught this in person to the nurse anesthesia students, but we were only in the country for 2 weeks. So we had to compress the course into a week and a half. So even though we had the advantages of in-person interaction and workshopping things on the whiteboard, trying to introduce that many ideas to the students in such a short period of time is really hard for them to be able to process. We were also invited to give our introductory quality improvement lecture to the psychiatry and nurse midwifery students. These are also advanced degree students who already have their nursing degree. And that was well received, and we hope to expand our quality improvement course offering to them in the future. So I'm going to change gears a little bit and talk about my hopes and dreams. So Professor Baro has asked us to help him build a better simulation center in the Gambia for many years. This is the state of the simulation in the Gambia with the only airway mannequin, which I couldn't even attach the lungs properly. And as you can see, it's not very realistic. And contrast this to, this is our, a picture from our Department of Anesthesia Simulation Center with Professor Baro. You can see here intubating our high fidelity mannequin when he came to visit us in November. And at the same time, you can have real-time vital signs that change from good to bad to hopefully good again if we do all the right things. So before the vital signs get bad, I'm gonna change the slide. So, you know, our simulation center is extremely expensive and very labor intensive and quite technical. And so the practicality of trying to implement something like that in the Gambia is really just not that feasible. So in an effort to kind of understand better what we should be aiming for, something that's more practical, Dr. Jenkins and I traveled to Dakar, Senegal, to visit their simulation center in their medical school. And we were very impressed. They have equipment from Laerdal. Everything is very high fidelity, but it's just at a level that I think is perhaps more attainable for us in the Gambia than what we have here. And so we're actively pursuing funding for that now. Other things we're interested in exploring are research. So pictured here in the pink shirt and the black jacket is Dr. Momodou Chang, and he is the CEO of Bundun Hospital, which Professor Baro mentioned is a women's and children's hospital. And Dr. Chang is actually quite the data guru. He collects all sorts of data on his hospital and his patients, and he likes to display them all over the hospital, as you can see here. And so we met with him along with Dr. Keba Ka, who is a Gambian who earned his PhD in public health from the University of Utah and is now at Indiana University. So we met with him and we asked to look at his data, and we noticed that there was almost no data on the operating room and definitely nothing on anything anesthesia related. So we're hoping to work together with Dr. Chang and Dr. Ka to collect better data that would be pertinent to the operating room and anesthesia, and with a goal to reduce maternal mortality. Other things that we're working on in the next year or two is I want to make the quality improvement curriculum more sustainable, because I don't think I want to teach it every year forever. So we need to teach some of the Gambian professors to be able to teach that curriculum to the students. Professor Baro and others have asked us repeatedly if we can help them with importation of more advanced equipment, because the Gambia is lacking so much in technology, especially capnography and difficult airway equipment. And I actually have a question for the audience at the end about this, because there's also a lack of biomedical engineering expertise in the Gambia, and there's really no pipeline for technical expertise to maintain, calibrate, and fix these machines. One of the Center for Global Surgery Fellows is Dr. Usman Sanyang, who is Gambian, and so we are exploring a collaboration with his department as well. And we also have contacted the University of the Gambia Medical School. As I was discussing before the talk, they do have a few nascent residency programs, and we'd like to be able to partner with them as well. So going back to our timeline, we signed an MOU with between Iowa and the University of Utah in 2016. We engaged in traditional teaching methods for about 3 years. Then COVID forced us to be online, but we were able to teach a quality improvement course for 3 years. So then when we returned in person, we wanted to deepen our relationship by introducing the case conference format, working more on quality improvement projects. And as we move forward, we'd like to be able to help them build a simulation center and continue quality improvement, as well as engage in research. So I'm ending this with a couple of questions. First, for Professor Baro. I've talked a little bit about the Gambian Society of Anesthetists, which is the national society unifying all the nurse anesthetists in the country. So what do you hope this group can achieve in the next 5 to 10 years to unify the anesthesia practice?
First of all, they should have a more participatory role in not only improving the professional standards, but also trying to work on in collaboration with government for the welfare of the anesthetists. Otherwise, I don't think anything will work. Now, for because they play a very pivotal role in maintaining professional standards, so they could also help in that as a society by way of organizing workshops, organizing conferences, and continuing medical conferences. The other thing is for the welfare of the membership, their work should commensurate with their salaries and good working conditions. That is not what is happening. So the association would be very pivotal in trying to help them improve that by talking to government and encouraging them to improve their condition of services. They would also be able to help to talk to mediate or be a liaison with government for medications and equipment to be available for good services. Finally, they should also be a liaison with international bodies and societies in order for exchanges, either physical exchanges or inviting international bodies to come over here and organize conferences for them. They could play all these roles.
So what do you think are the next steps?
The next steps should be, number one, first of all, they need to organize themselves very well. I think the society had been very lax. They have even been trying to organize a Congress, which has still not happened. I have pushed them so much, but I think we will have to start from the Congress. Then that is where one will start to talk to them about all these things and that they should play an important role in all these things.
And then my next question is actually for the audience. Since we are considering the donation of equipment, which traditionally we have shied away from for many reasons that I think everyone in this room knows. So as we consider doing this, we have two questions. One is, how can we study how effective or harmful the donation of equipment actually is? And then how can we prevent this from overshadowing our primary mission, which is to share knowledge and clinical expertise? Dr. Judkins.
Professor Baro, it's lovely to meet you. My name is Allison Judkins, and I am not an anesthesiologist or a surgeon. I'm a neonatologist, and I spend quite a lot of time in Nepal. I have a question sort of back to help maybe answer this question. And one is related to how effective or how active the government of the Gambia is in the sort of obtaining of the equipment. I think all of us in this room have probably been in places where equipment is donated, and to your point, hasn't been updated and there's no one there to fix it. I can't tell you how many warmers I've seen in Nepal that are now glorified shelves because there's no one there to fix it, or it exceeds the capacity of the energy supply. So my question is, when we consider donation of equipment, where it's normally sourced from, if it's another country in Africa or locally in the Gambia, what role the government, either centrally or locally, play in the procurement of equipment, and then what the sustainability of the supply chain would be. Because it's one thing to put up a capital investment for bigger equipment, but for things like monitors, pulse ox, things that sort of run out, lose their equipment, sort of what that process might look like if we think about moving forward with capital investments for things like equipment.
I think that's a very good question. In the first place, the funding available for replacement of buying new equipment and replacement of old ones, the availability of the funds is not there. So what do? We rely on international organizations like WHO, especially UNICEF and UNESCO. They are very helpful in that. And where do they get the equipment from? Anywhere they can get it from. And that is the problem. We do not have standard equipment in all, as you have over there, in all wards or all departments. It's not available. That's not so. So that is very, that is one thing that is disturbing us in this country. We don't buy equipment specifically, and we don't have a standardized type of equipment for, like, all over the hospital. You will go into one operating room and find some kind of equipment there, and the next operating room has completely different equipment. Yeah. That's number one. Number two, we do not have the medical biotechnology people. We don't have them here. So whenever a slight thing could happen to an equipment, and we will not be able to use it again. So if you go in the backyard, you'll find lots of equipment dumped there, probably because they have very minor faults. That is a major problem. So we need to, first of all, have biomedical engineers to be trained, at least in order to be able to do minor repairs. And again, there has to be funding to buy standard equipment all across the hospital, which is not done. So that is a problem. I think the whole reason is because we do not have the funds, and it is anybody who can buy anything and send it to us. That's what we use. Does that answer your question?
Thank you. Yes, that's very helpful.
So I'm wondering whether you are connected in any way with the WFSA, the World Federation of Societies of Anesthesia, and also whether you have any connection with the G4 Alliance, which has a network of organizations in global surgery, including anesthesia, but also including surgery and biomedical equipment. So there's a network of people who work together to solve some of these problems regionally. Are you working with any of these groups?
That is the reason why when I was asked about the role of the society, that's why I said they must liaise with international organizations. I have told them about the World Federation all the time. They started communicating with them, but it did not complete. For this, the second one that you're saying, I don't know about those ones, but I know about the World Federation, and they can be helpful.
I also wanted to know about the training for pediatric anesthesia and regional anesthesia. Are these part of the nursing curriculum?
Yes, it is part of the nursing curriculum. That's what we teach there, and especially pediatric anesthesia. Regional anesthesia, somebody else comes to teach it, but that's one area that we concentrate on most, because general anesthesia is, regional anesthesia is much easier to administer than general anesthesia. So we teach them a lot of that, because most of the time that's what they do.
You know, your question of how do we study effectively? I think that's going to be an important concept, as many preconceived notions that donating anything is almost bad because it doesn't work out over time. Whereas a lot of the donations actually do help for a period of time and provide improved access, improved care. Even if it works for 2 or 3 years, it does. And during a time that the economies of countries improve, that they begin to develop more business models to be able to support things. That I think looking at, I mean, I see so much written about negative about donations. It'd be very interesting to look at, but what are the positive things that are coming through the donations? What are the metrics you want to use, i.e., what businesses have been formed to support it? What, how many people have benefited from the donations, even though it may not be working when the incubator is not working for a while? Did it work for a while? Was it used for a period of time? How long was it used for? Was there any training associated with it? I think there's a lot of questions that could be asked about how beneficial is this as a part of it is a stopgap intervention until things change to be able to supply it. So I guess I would, not so much as a question, but as a comment, as how do we study it effectively? I think really cautiously look at what the metrics are that we want to study, that then we could take those and find, well, how could even make donation even better, longer acting, until people, and how does it help support the development or harm the development of the businesses that can support it? In Mongolia, when we were donating so much, just for example, the trocars for laparoscopic equipment, one of the colorectal surgeons came and said, you're killing the ability to develop the businesses to support it because you're bringing so much stuff. And so we transitioned to how do we develop the businesses to support what we're doing and to help those grow within the country as well. So anyway, I just think it's a very interesting question that is much bigger than just, is it useful?
Thank you very much. I think this is very salient. But I think, first of all, one must not depend on donations all the time. I think it's high time we start thinking of how to sustain ourselves. However, before, donors would just bring in anything at any time. But at least there are donors who would ask, what do you want? In which case we would tell them what we want. There are so many things that are dumped in the hospital there that are not used because we don't need them. We don't even have the know-how to use them. But now we talk with them, when they ask us or we tell them what we want, and that's what we use. And to be honest, most of these equipments are used for a very long time because we don't have replacements. Unless they break down, we will continue to use them. That's what we have been doing all the time. So that would answer the how long we use them. So we use them as long as they have not broken down. And when they break down, that's maybe for a very small reason, We just put them aside because nobody knows how to repair them.
Momodou, would the presence of equipment, let's say capnography, if we had it there and then it broke down, would the fact that it already existed there, would that improve the odds of it being replaced by the government or some other source?
Well, count out government because, to be honest, the only thing we are sure of government doing is paying salaries. But there are many more things. We owe lots of countries, a lot of suppliers, monies that we should pay them for equipment and medication. So replacement is out of the question. It will not be replaced. Probably we now have few, I think, Cuban biomedical engineers who may try to repair them. And that's what we would rely on rather than government replacing it. They would not, they cannot, even if they want to, they cannot replace it.
Is there, Catherine, anything of a really evaluation and analysis of companies that supply Africa, where they're from, those kinds of things, which countries, for anesthesia equipment, for surgical equipment, because we've looked at this as in terms of.
Yeah, so there's a lot of discussion right now in WACS, in the West African College of Surgeons, also in the Eastern region, COSAXA, about developing consortia, because each country has the very same problem that the Gambia has for acquiring equipment, both anesthesia equipment and also surgical equipment. I'm a urologist, so, the equipment for urology, if you only have one center that's using it, distributors are not going to make a great effort to supply it at a cost that people can afford. However, if there are consortia for buying things, they can get them at a cheaper rate and also negotiate replacement and all of the consumables that are necessary to make that equipment function. Because the standalone equipment is no good unless you also have the appropriate consumables. And what has happened with a lot of people, even when they're in private practice, is they get this odd assembly of a little bit of Chinese this and a little bit of American that and something from Germany here and there, and they don't interoperate. And so having a sort of relatively consistent set of equipment in a region can help with procurement. So I am wondering if there are close enough relations between Senegal and the Gambia and maybe some other regional relationships that may help with getting consumables as well as durable equipment, because it does no good to get something from the United States that won't interface with whatever else you're getting from China or Pakistan or pick your other place that won't operate with that equipment.
Actually, there is not such a relationship between the Gambia and Senegal. Yes, for consumables, they have more consumables than we have, and sometimes we do go by. But Senegal is involved in this, what we call PPP, public-private partnership, where organizations like Siemens, companies like Siemens would bring in their equipment into Senegal, into their hospitals, and they will share the profits. The equipment will be used, and the hospital will share the profits with Siemens. That's the kind of thing they do. So that's why they have a lot of equipment available, which we don't have. But I think the Gambia government is trying to do something like that, where there will be a public-private partnership, and all these things like laboratory equipment and MRIs and all those equipment will be available, provided for by a European company and
Yeah,
completely operated by the European company, and they share the profits at, I'm sure, a 60-40% or 70-30%.
yeah, it's interesting how the business models of these things work, because there had been a time when there were Francophone consortia and Anglophone consortia, and they didn't overlap in terms of consumables. But I understand that has changed somewhat, and some of these consortia have now changed over to the model you're describing now for Senegal. But what I don't know, and maybe some of my colleagues who work more in Ghana and some of the other Anglophone countries, how they are approaching this same problem. Do you know, Brad or Ray?
No, I
I've
don't
not heard
have.
of any consortiums in Ghana.
Yeah, it's a topic that comes up a lot for discussion when we look at the rate limiting problems in each country, because some of them are unique, but more often they're similar. But that question doesn't seem to come up when people are having meetings. They tend to talk about procedures and case conferences and not how they're going to get the materials that are so critical to everybody's daily function.
I think for the Gambia, the problem is because of the size, some of these
Yeah.
thought here would think is not worth venturing it. So they would rather go to bigger countries like Senegal.
Another meeting in here.
Although I think that's true, that there are other in Africa, other small countries, maybe not quite so small. So it might be worth exploring, and this is where some of these international groups like the G4 Alliance can leverage a larger forum, I guess, for conversation about how to be creative. Might be something you'd want to bring up for one of those. They have Zoom meetings. There are different subgroups. Anesthesia is one of them, and there are African subgroups within that.
That's
Yeah.
So they have another group that's scheduled, so.
Are we?
that is worth exploring.
All right, I think our time is up. So thank you so much for coming or for watching online, and see you next week.
Great, and thank you, Mo.